All right, so basically the layout of the whole book is, this is just it, anatomy, assessment, action. So we start off with the foundation of anatomy for all the different parts. I think you might have seen this section right here. So I go through evidence, law and ethics, informed consent, draping, and some self-care ideas. Then we go into outcome markers for about a few pages there, and record keeping, muscle testing, treatment foundations. So we have treatment foundations, then massage techniques, then hydro. Exercise therapy makes up about 10% of the book by page count. But for each of the conditions, and this is one of the things we found in our research in our focus groups, was that students are missing what exercises do I do for what injuries. So we spent some time here going through all of those. And I mean, same thing, graded exercise exposure. So you can see like dead bug, how you start super light and then gradually increasing loads and all this kind of stuff. Then neurologic review, quick discussion of nutrition. What I really like, it's really more for instructors, but all kinds of outcome measures that you can use. So you can actually see grading schemes that are used for like board exams and all of that. And of course, practice management, which includes, what do we have in there? We've got, well, again, how you lay out your clinic room, all of this kind of stuff. Also how the contracts should look, what insurances you should have. And then of course into the appendix and references index. So I'll cycle through this pretty quick. I don't know if you know, what's his name? Richard Lebert. He wrote a few sections in here of some really good stuff. I really actually like his writing style. So a bunch of good content. Yeah, totally. And we're looking at this graph down here at the bottom. I'm just trying to create this idea of gradually increasing load over time, having a peak application, then finishing off with that. You know, and of course I still have to stick to the general to superficial to basic, and I mean, general to specific, superficial to deep, all of that stuff, right? Yeah, Richard did some other stuff too. We look at the actual anatomy education hours. This is one of my favorites, actually. Let me go back up to that for one sec. Is every year I show this, yeah, whatever. Every year I show this and someone complains, this isn't accurate. There's no way that a massage therapist could have more anatomy training than a medical doctor, blah, blah, blah. And I'm just like, okay, why don't you go ahead and send me your academic calendar? Let's make this evidence-based content right here, right? And every year someone does this. This has been out there for about 7 years now. And every year someone gets all hyped up about it. And I have had 0 replies once I asked them to show me, actually, what do you got for the content right there, right?
Yeah.
Yeah. You know what I mean? When it comes to soft tissue, that's where massage therapists spend their time. But we talk more about research literacy later on too. But big thing on history of massage. So yeah, here you go. So you're talking about it, interpersonal communication skills, right to start with. What the therapist can do, share knowledge, sit with pain. What they can't do is make decisions, right? Do the work for you, all of that. So all of that's there with our evidence-based, biopsychosocial, and shared decision-making models that we're following with this. And then I put this in there with references so you can see potential benefits of massage therapy. And I know that this is not the best, thing to carry forward, but it shows potential ideas that might be associated with. What do we cite here? Something like 52 articles on these 2 pages right here, right? For people to kind of look out where they might find information. Then we talked about, and this is the one I wanted to see, was this how massage therapy actually will work, all right? Or potentially might work. Contextual factors, therapeutic contact, pain modulation, then mechanical factors coming in last. Again, another 45 or 50 or so references, so you can see, you can break down the concepts there, right? And then why does it do this? Yeah, I put this as a 2-page display. It's just the way my brain works to show information. Contraindications. I feel like we have to have a baseline of contraindications at least to start with so people can kind of think about it, even though, of course, it's a case-by-case basis. Key red flags of violent trauma, carcinoma histories, all of that kind of stuff that you have to rule out, right? Law and ethics, ton of pages on this, just looking at boundaries, professionalism.
Why would you have violent trauma as a contraindication?
Well, if you have violent trauma that you actually have, potentially broken bones or something that might be a deeper tissue, like people can walk into your office with full-blown fractures. You may not want to be massaging. Yeah. Okay. Yeah. Law and ethics. Yeah. Proximity and all of this, common errors that people make. Then we go into massage hygiene, informed consent. Informed consent is like again and again and again. And it's all part of that communication picture that you want to have for patients, right? All the draping stuff, patient contacts. And then the assessment, we go through and we follow our basic, OHIP protocol that we go through all of the processes. So all the conditions are laid out the same way, looking at greeting and observation, informed consent, going through your history, Finishing off with, these things can go in any order that you want rather than being so rigid. That's one of the feedback points that I have actually is too many schools are like, it's got to be this way. And there's no flexibility around the process that they're teaching, right?
Well, because they're just teaching to board exams. They're not.
Well, I know. Yeah, they are. And the board exams are not representative of practice, right? So this is a big problem that we're dealing with. Oh, this is one that I really like, the motivational interview. Stop teaching dependence, start instilling resilience, and a couple of references on articles right there that you could read more if you wanted to. Yeah, so what my process is basically this. We go through and do our research on it. How many articles are on this one? I don't think there was too many. I think I had about 7 or 8 on this one. Regardless, then we make up an infographic on it. So these are the key things that should be involved in a motivational interview, right? History considerations, past and social history, and then a bunch of stuff on the outcome markers. I'm not going to go through every page. Just wait. I skimmed by too fast. Pain assessment, pieces of the pain puzzle, realizing how pain perception is done, current pain versus worst pain versus best pain, functional capacity evaluations versus self-reported evaluations, right? All of that good stuff.
Well, there's even research out there now that's showing us that we shouldn't use a pain scale.
Yeah, yeah, exactly. That's 100%. Yeah, because it reinforces the process of where I should be on the scale somewhere, right?
Yeah.
So, yeah, pain gate theory. I still put it in there because there are still people who are there behind it a little bit. Not the best thing, but still out there for us to look at.
It's still sort of the history of how we understand pain. It's outdated now, but it was one of the things that talked about pain. So there's nothing wrong with knowing it. It's just not applying it.
Yeah, and one that we do at all of the books here is the fear avoidance model associated with pain and injury, right? Where the person is cycling through into that disuse, disability, and all that. And then, of course, just more basic stuff like body mass index. I still talk about posture and everything because there's no school that's not going to have posture. Skin lesions are all there, of course. Palpation, flexibility, fitness assessment. That's actually a good one. The fitness assessment, that's been my kick for the last 2 years here, has been just doing all these posters up and everything like this. We have like something like 1,500 different exercises you can do, but rating yourself overall to see where you are in your fitness ability and then recording your data and tracking it over time, right? For sit-ups and all that, just like Canada fitness testing used to do. And blah, blah, blah. We don't have to do this. What I really want to show you though, Jamie, to get your feedback on was the massage therapy. Yeah, SOAP notes, prognosis, all of that good stuff. And then I still go back to, though, a tissue-specific recognition of what the injury might be. Like, is it muscle? Is it fascia? Is it ligament? Because the healing times are different on different tissues. So if you're going to create a prognosis for someone, it's a good idea to know which tissue is damaged, right? And for you, like if it's a nerve injury, they better have numbness and tingling and other things associated with it, potentially to be, the classic compressed nerve type injury thing and visceral stuff. Working with pain, of course, always starting and focusing on the goals and then cycling your way through all of that. This 300 days of healing, loading a tissue, not a big deal. Therapeutic order. Okay, so this is one that we have to kind of talk a second about. How much time I got? Yeah, I got about 5 minutes before I got to boot you out of here. Just working your way from least invasive to most invasive. What I'm basically doing for everything that I'm writing, everything that I'm teaching is minimal effective dose. What is the least we have to do to help somebody get better? I don't know if you're using that terminology, but all right. And then I basically break it down just like Rattray did, muscle spasms, muscle strains, tendinitis, ligament sprains, where we talk about it. How do you recognize it? Key things for the injuries that happen, contusions. And then, Susan Chappelle, what a golden person she is. Fantastic. Scar tissue in detail, over 100 and something references on this section. What is the scar tissue? How do we cause adhesion? How do different tissue types heal? So if you're looking at, muscle injury healing versus ligament injury healing, how you can have different therapeutic interventions at different times and stages of the healing, and when you're going to see the best benefits. Because I think what happens right now is a lot of massage therapists, they're scared at the very start. If it's acute, I can't do anything. Like, it's a scary time for them, right? Mm-hmm. Yeah. So if you're looking at all that.
Is she talking about like breaking up scar tissue in a treatment?
Nope. She's talking about how you influence the healing process of it. And in fact, if you read the research on cross-fiber friction massage, you're most likely actually probably causing the tissue to become more dense than anything if you're actually being that aggressive into it.
Especially when we look at tendon injuries and that, it's like completely, I wouldn't say contraindicated, but for lack of a better term, contraindicated to do cross-fiber frictions on a tendon.
Yeah, exactly, totally. So anyways, this is right here is the tissue forces. This was the graph that made all of this happen right here, Jamie, okay? All right, so this was us to go ahead and look at, these are some basic forces. You should still be aware of the mechanical properties, but what is your ability to influence? That's the question right here, right? You're mechanically influence it. But then I break down each of the treatment types where we made breathing techniques, meditation, where I basically made this little graph that goes procedures or table procedures, the application, and then the notes that you might have to have around it. So each of the treatment types are shown in here. But again, if you look at everything I write here, at the end of each one of them, it says more research is needed, more research is needed. So we say, oh, there's an article that says this and this and this, more research is needed, right? What actually does have good research is tap ointment with cystic fibrosis. So I spent a whole page showing the basic body positions that you could change into draining different regions of the lung, right? So yeah, so all of that, but that's basically it. Just a little bit on trigger point therapy, but again, that's, highly, highly contagious, controversial. All right, ice and stretch.
It's a nervous system thing, right? Not a muscle thing.
Well, yeah, exactly. And then what I do is we actually lay out, I think, 12 different theories on it or something. So yeah, joint mobilizations, cupping, instrument assisted is there, even a little bit on the K-taping and all of this. And then it goes into, of course, all the hydrotherapy. I'm not going to spend all your time doing this, but that's basically the layout of the book. Oh yeah, maybe I should show you the exercise therapy. Once I get there, ka-chunk. My goal was to replace Rattray with this text, right? I wanted something, and the other thing, as you know I do, we update our books every 2 or 3 years. So if there's something new that's been shown, well referenced in the literature, we update it and make sure it's in there. Exercise therapy. Here is your gradual building stages of resilience and exposure right at the very start. So it's looking at injury and then progressing all the way up to full functional speed and a return to activity. Yeah, exercise benefits. I mean, the only real risks with exercise are associated at the very high ends where you're looking at increased risk of injury or osteoporosis and all of that if you're extremely rhabdomyolysis and all of that stuff. Yeah, so protecting your back, all of this stuff. And then each of the chapters breaks down into literally exercises after exercises of whatever body region you want to work on, just as general ideas. Yoga, stretching even is there. And then, of course, all the rehab protocols, which are actually designed for the patient to take a picture of or you to photocopy or print right out of the book and give as a handout to the patient. Research.
The timelines, like when it's appropriate to do an isometric and then a concentric and an eccentric.
Well, all that's gonna vary from person, as you know, that varies from person to person and case encounter, right? But it's also gonna depend on your confidence and skill set and experience with a given condition. So all of that's gonna vary too. But yeah, we talk about that generally. I give a basic outline of that in the very start for a generic treatment, like 1 to 2 weeks, consider this 3 to 4, but it depends on the tissue specifically that's injured, right? If it's a tendon injury, the healing time is going to be slower. If it's a muscle injury, the healing time is going to be faster. And it does relate to blood supply of that tissue. So generally better blood supply into tissue means better healing into it. But that's the body's own blood supply into it, not what we're initiating into it, right? And then, so each condition is laid out like this. Like here's whiplash or cervical sprain strain. Even trying to avoid the word whiplash, right? Because of the connotations associated with it. I literally have 2 minutes left. And then, of course, we finish off with some basic rehab exercises and things you might do, going through anything from the basic management and general treatments, massage therapy in acute stage versus subacute into chronic, and then joint mobs, acupuncture, medications, and surgery. Even though those things are out of scope for massage therapists, depending on your jurisdiction, it's still important for you to be aware of what other treatments they might be having or what other practitioners might be doing. And then we talk about rehab programs, patient monitoring, education, prognosis, and medical legal reports or medical legal issues that you might have with it as well.
So just quickly looking at that one, I just quickly noticed that you're saying like recommending using MLD to reduce the swelling of the head and neck, but
well, just wait. I know. So yeah, exactly. Get me on that one.
There's no research, no quality research around it.
You're right. You're absolutely right. But the thing is, what do I have to do? I have to connect the dots from Rattray to bring people up a little bit so that it gets adopted, and then we can move forward. Because I'll tell you right now, nobody is going to be redoing all of their board exams because you give them a couple articles that say, well, this is the current research and what it says. The colleges are all, like the accreditation colleges are all like 10 or 15 years at least behind the current research. Yeah, and right? And so that's what we're fighting. So this is the thing, is like a lot of people will take this stuff and they'll say, well, that's not right. And I'll say, you know what? I agree with you, but we have to start somewhere, right? So that's kind of where I am.
You asked about like when you're putting stuff out online, what you could do better.
Yeah.
Do that, man.
Yeah.
Start putting it out and saying, I know that stuff is wrong.
Yeah.
This is why it's in here.
Yeah.
And until we start to change the board exams, until we start to change the college setting, and they're examining on this, that's why I put it in here, because that's what the student's going to be examined on.
Yeah, exactly. And that's where you're kind of stuck into this, in this transition time. That's really good advice, Jamie. Thanks for doing that. Yeah, the biggest thing is, anybody can take pretty much any work that someone's created and say, well, this isn't right because of this article or that article or whatever it is. But you're right. We ultimately are looking for the best outcomes for our patients. One that I really like is this one on concussion right here. Yeah, I basically contacted, who was this one? This was the British Medical Journal, BMJ here. And for me to use their illustration, they wanted to charge me $1,500 for it. So I said, forget that. I'm just going to draw my own, change it all around. And we created this one for, it took me all of 2 hours to make this. And it's the key strategies for the evaluation of concussion based on current evidence-based content what I tend to do is simplify things as well, right? I like to take large amounts of information and make them into a more usable content, right? Lumbar disc herniation, looking at, McKenzie, Williams exercises, all of that stuff, right? But I want to get through all the pathology stuff. I mean, it's a culmination of, effectively 20 years here. Even the special tests that I put in there, all they are is the most basic common special tests that you actually might consider using, like a straight leg raise or, something that actually has decent research behind it.
Did you put anything about specificity versus sensitivity?
Jamie, have you seen the orthopedic assessment book?
No.
Every special test that has research that we could find on it has likelihood ratios, positive and negative predictive values, and sensitivity, specificity, and reliability factors on all of the tests.
Good.
Yeah. I'm just trying to get through the pathology here. This computer's a little bit slow, but I can already tell I got to change the color of my bone on this thing here. Oh my gosh, will it ever end? Okay, we get into some systemic stuff as well. Stress fractures of the foot, we don't need to see that. Neuro, we don't need to see. Okay, then I go into nutrition where I talk about just some basics that you should be aware of, like, all the vitamins, calcium, and all of that's there, all the minerals. Canada Food Guide has got information there for us. And then we go into the evaluation forms. And yeah, so if somebody wants to, neck disability index, low back oswestries, there's about 40 of them we have up on our website that people can actually fill in online. DASH, lower extremity functional screens, all of that is there. And then the different assessments that you can do as well when you're testing as students or being tested by a proctor, so students can see what they're graded on. And then clinic forms that you can actually use. I got a number of doctors down in the US right now. Amy Watson is one of them, actually. Just messaged me this morning, and she's converting these over to be usable in Jane. So all of these forms will be available in Jane as kind of a playbook for people to follow. What are the key things I should be evaluating when I'm doing my assessments, right? And then this is the layout right here for the treatment room, management, practice options, how to start up a clinic, marketing, biographies, insurance that you need. So all that finished, and a business plan. And then I go more into research literacy. So you can see how we actually rank our data based on the quality of the research that's given. Of course, Oxford levels of evidence. What is this? Hills and Koch's postulates of causality to look for actually, is this good information? Bradford Hill criteria as well. Also, the 20 forms of bias you may be suffering from when you are doing an evaluation, okay? When you are looking at research or whatever else it is. And then this is where we break down the likelihood ratios. What does sensitivity and specificity actually mean? Clinical problem solving, clinical prediction rules, of course. And then I break it down into some taping and everything to finish off the book. But yeah. And then I even included it. Electrotherapies are there, relevant for some places that have to do it. So there's electrotherapies in there. And a little bit, full glossary. And then, of course, references, index, and that finishes you off right there. So that's kind of the layout of the book. But like always, I'm open for feedback on anything. So just wanted to give you a quick look at that really quick.
Right.
Yeah.